Intermittent fasting has drawn intense interest in oncology circles for its potential to influence cancer metabolism and improve treatment outcomes. Laboratory studies and animal models suggest that periods of food deprivation can shift cellular processes in ways that may slow tumor growth, increase stress resistance in healthy cells, and enhance the efficacy of chemotherapy. These findings have sparked hope that fasting might serve as a non-pharmacological tool to support cancer therapy. But translating these effects into clinical practice is far more complex, and for many patients, particularly the frail or metabolically compromised, fasting may introduce serious risks that outweigh any theoretical benefit. At the cellular level, fasting triggers a cascade of metabolic changes: lower glucose and insulin levels, increased ketone production, and activation of autophagy, the body's mechanism for clearing out damaged cells and proteins. These shifts may put certain cancer cells, especially those reliant on constant growth signals and nutrient availability, at a disadvantage. Preclinical research has shown that fasting can make tumors more vulnerable to chemotherapy, potentially enhancing treatment effectiveness while protecting healthy tissue from collateral damage. Animal studies have even reported delayed tumor progression and improved survival in response to structured fasting regimens. However, what works in mice often fails to deliver the same impact in humans. Human metabolism is more variable, and cancer patients are not metabolically healthy individuals. They are often under chronic stress, inflammation, and catabolic strain from both the disease and its treatments. Introducing fasting into this fragile system can lead to unintended consequences, especially in individuals already struggling to maintain weight, muscle mass, and nutritional balance. Malnutrition and cancer cachexia are not just common, they're often lethal. Even short-term fasting in such patients can accelerate decline in energy reserves, immune function, and organ stability, reducing the body's ability to tolerate aggressive therapies. Clinical trials on fasting in cancer patients remain small and preliminary. Some have reported good tolerability and even improvements in treatment side effects like fatigue or nausea, but these studies are often underpowered, lack long-term follow-up, and involve highly selected participants, typically younger, well-nourished, and highly motivated individuals. They do not reflect the broader population of oncology patients, especially older adults, those with advanced disease, or individuals with concurrent conditions like diabetes or cardiovascular disease. For these groups, fasting may destabilize glucose regulation, increase risk of dehydration, or worsen treatment-related complications such as electrolyte imbalance or hypotension. There is also the psychological toll of fasting to consider. In patients already dealing with food aversions, taste changes, or digestive distress from chemotherapy or radiation, adding a rigid eating window or prolonged fasting interval can heighten anxiety around meals, lead to disordered eating patterns, or reduce overall caloric intake unintentionally. For those at risk of depression or isolation, fasting protocols may compound emotional strain and lower quality of life, factors that are crucial to long-term outcomes but rarely addressed in fasting literature. A further concern is the growing number of fasting protocols being promoted outside of clinical supervision. Some patients are turning to social media or unverified online sources for guidance, experimenting with prolonged fasts, water-only regimens, or extreme time-restricted eating without medical clearance. In the absence of dietitian input or regular lab monitoring, these practices can quickly lead to deficiencies, hormonal disruption, and even emergency hospitalization in vulnerable individuals. What begins as a hopeful experiment can spiral into a dangerous spiral of weakness, treatment delay, or irreversible nutritional damage. That said, fasting may still hold potential in oncology when approached cautiously and selectively. Short fasting windows, such as 12 to 16 hours, may be reasonable in metabolically stable patients, especially if guided by clinicians and integrated into broader nutritional plans. Some research teams are exploring fasting-mimicking diets, carefully formulated low-calorie regimens that simulate fasting's metabolic effects without complete food deprivation. These offer a more controlled and potentially safer way to harness fasting's benefits while minimizing harm. But even these strategies require further testing before they can be widely recommended. In the end, intermittent fasting in cancer care remains a double-edged sword. Its metabolic rationale is compelling, and early research is promising, but its risks in the real world, particularly for patients who are already vulnerable, must not be overlooked. Until robust, large-scale clinical trials provide clearer guidance, fasting should not be seen as a universal solution but as an experimental approach to be considered only under close medical supervision. In oncology, where precision and personalization are key, oversimplified dietary interventions, no matter how trendy, carry real consequences when applied without care.